Assalamu alaikum. Your Highness, Sheikh Moza bint Nasser, Your Excellency, the Prime Minister, Mr. Abdullah bin Nasser Al Thani, Your Excellency, the Health Minister, Abdullah bin Khalid Al Qahtani, distinguished guests, President, Dr. Bates, ladies and gentlemen. May I just say it's a great privilege to be given this plenary at ISQua, a meeting that I've always held high admiration for. May I also congratulate you on the 30th anniversary to choose Doha. This is a country that has embraced quality and safety as a core principle in their healthcare reform agenda. My mother used to say when I was 30, life starts at 30. I think she was trying to get me married. And I could only tell you life will start at 30, being in ISQua, certainly after being in Doha. Sadly, I only came to Doha at the age of 50, but I've had a fantastic 5 years. So enjoy it all. It's a fantastic city, and you're going to see some amazing innovations in health and science, which I'm sure will be very inspirational. Now, it's worth reminding ourselves that science, which is embraced very much in the vision of Her Highness in this country, has had a huge impact on life expectancy. I don't think there is any other sector that you can think of which has had such an impact on mankind. Scientific discovery and its translation has doubled our life expectancy in 100 years. You give me one other example that has had such an impact. Finance, no. We live better, but scientific discovery is really what is added those wonderful years to our lives. Most of it was public health in the beginning of that century, but in more recent times has been innovations in diagnostics and therapeutics. So it's all a great story. However, if you put the magnifying glass a little bit closer, you will be slightly alarmed. And that is, our service delivery models are still harmful. If you compare us, what we think are dangerous industries, like the airline industry or the nuclear industry, my chances of dying flying from London to Doha is 1 in 10 million. Thank goodness for that, because I do this trip once a week. If I was treated in my own hospital at St. Mary's Hospital in London, my chances of being harmed is 1 in 10. That's a huge and a phenomenal challenge. As we become better, technology is enhanced, but at the same time, our systems have become more complicated. 2,000 people in the United Kingdom die a year from avoidable harm. A larger population in the US, nearly 100,000 people die of avoidable harm. If you add that for 6 months, that is more people lost in hospitals than the war in Vietnam many, many years ago. It's a waking up story that safety, which is really the principle of this wonderful organization, ISQua, still remains a challenge. Earlier this year, and I could see some faces here, in February, Qatar Foundation won this wonderful meeting under the patronage of Her Highness Sheikh Moza, which is called the World Innovation in Healthcare, WISH. It's been running now for 3 years, and this year, its main aspirations are, what are the innovative solutions, some of the complex problems facing us in health systems? And believe it or not, patient safety was in the forefront of the 2015 meeting. It was led with no other than Peter Provost, one of the most distinguished leaders and academics in the fields of patient safety. And what was unique about his approach, we need to look at safety not as an individual phenomena, but more of a systems approach. He very eloquently highlighted some of the major challenges facing us when it comes to patient safety. I'm just going to name a few of them. Patients and families have become increasingly engaged, but not enough. Education in patient safety has advanced, though still remains superficial. Metrics have increased, though their validity is largely unknown. So still, a large number of challenges, as highlighted in the WISH report, which I strongly recommend you read. You can download it from the WISH website. Still, there are major challenges when it comes to issues of patient safety. The next 20 minutes or so, I'm going to share with you some of my own work with the wonderful team that I work with back in London, but also in Doha. These are examples of starting off with what I describe, how could we change cultures and behaviors when it comes to patient safety. So, starting off with this concept of nudging behaviors. We know, most governments know, if you want to change the behavior of the population, you have about 2 or 3 tools. You can use taxation. The sad thing about taxation, the more you increase it, the vulnerable are the losers. Regulation is another one, making things illegal. We also know that the more you make something illegal, there's something about mankind, the more they want to do it. The third is how could we nudge them in the right direction in terms of policy, which is an area I developed an interest in about 7-8 years ago, which is very much bringing psychology, economics, and policy together. Why behavioral change is important? Let's look at the facts. We know 50% of the deaths in the United Kingdom and the United States, and I'm sure it's the same worldwide, is related to the choices we all make. That's the public and the patients. That is the choices, what we eat, what we drink, what we smoke, and so on and so forth. Now let's move away from patients and public. Look at clinical practice. 45% of clinical practice does not follow evidence-based guidelines. That's an alarming figure, 45%, despite all the scientific discovery I mentioned earlier. What about the economics of this? I'm delighted to see that His Excellency, the Finance Minister, is not here because he will use this as a weapon against us. 30 to 40% of spending in healthcare is discretionary without having any beneficial impact on outcomes. That's the fact. That's the evidence. The question is, why do people continue to do the same thing again and again and again? And psychologists have studied this over the years. Humans are predictably irrational. We repeat the same mistakes again and again and again. So behavioral economics is combining the insights from psychology, the laws of economics, really demonstrating many of the biases that we come up with. And in 2007, we had the privilege in the department, some very bright lecturers in the department who worked with the Cabinet Office in the creation of this document called Mindspace, as part of the Behavioral Insight Unit, which actually was based in the Cabinet Office. The purpose of this unit was, any government policy coming out, could we look at the policy to see whether we can improve it or make it more human, so the chances of it succeeding is greater than a piece of policy going out into the system. It has 9 attributes. Mindspace stands for Messenger, Incentives, Norms, Defaults. I'll give you a few examples. Looking at Messenger, we know for a fact from a large number of studies, if a clinical guideline comes out from ISQua versus the Department of Health in UK, the uptake by clinicians, if it comes out from ISQua, is about 82%. If it comes out from the Ministry of Health in London, it's about 16%. People believe in professional societies. They believe in the messenger. That's an interesting fact. It's a true fact. Looking at incentives, I've never appreciated this. People value or get more upset about a loss, in incentives rather than a gain. So if you lose your bonus, it's much more painful than getting your bonus, and you tend to forget that. Default, fantastic study when it comes to organ donation. You know there are two systems of organ donation. You either opt in other words, you register to say, I would like to give my organs for donation, or you opt out. In other words, the system automatically considers that I am going to give my organs, but I have to go into the system and remove myself if I don't want to give my, and that's the default. The default of opting out, in some countries, the yield of organ donation is significantly higher than those who have to fill in a card to say, I would like to donate. So these are the very simple tweaks in policy that can have huge impact, which brings me back into why am I looking at this in terms of patient safety? Hospital-acquired infections is a major challenge. 5,000 cases a year in the United Kingdom. It costs the NHS 1% of its budget. Having MRSA, bacteremia, Clostridium difficile is a serious, serious channel. We tackle some of these with design, in improving behavior in a ward environment or primary care, but I really wanted to drive the concept of hand washing. You may know, this is true fact, in the busiest unit, only a third of the doctors and nurses will be washing their hands between seeing patients. No surprise, we have these challenging morbidities and complications. Education, regulation will work for a few weeks, then everyone goes back to the normal. How could you drive this change in really washing the hands or using the gel? Now, you can place the gel at the entrance of every ward. You can place the gel beside every bed. Still works for, you can increase awareness, it works for a few weeks, and everyone is back to their normal. So we've looked at the possibility. What is the influence of an eye watching the machine, the gel machine, or the sink near the bed of that patient? This study was based on a wonderful study which was published from a group in Newcastle, and this group looked at an image of a pair of eyes on the contributions to what we call an honesty box used to collect money for drinks in a university coffee room. So the students will make their coffee, they have to put their 10 pence into this honesty box as a return for someone to go out there and buy the coffee and the milk. What's fascinating about this, you can see the images of the eyes versus the control, which are the flowers. If you put the eyes of a male, 6-time increase in the donation to the honesty box. What's also interesting, the male eyes had a considerably higher contribution than the female eyes for some reason. I suspect it's more of an aggressive look, a problem with men, but there you are. The second study was to look at the impact, the non-conscious impact of smell in terms of washing your hands. The smell in a ward or a smell into the entrance. This was another study done which looked at students who were primed with a scent, which was a citrus scent in their environment, and those students were more likely to clean their environment and their rooms when exposed to a clean smell, in this case, as I said, a citrus disinfectant. So we went back to the ward, we added the eyes, a male and a female eye, and then we brought in the scent. We put in a citrus spirit, you know, the hospital smell. We increased that concentration in a ward environment and run this experiment. And you can see the impact on the experiment. Actual fact, the olfactory, in other words, the smell or the scent, increased the hand washing by about 30%. And may I just remind you, this was non-conscious. So people weren't aware this is happening, which is really the beauty of this, rather than telling them you have to wash your hand. You compare that with male eyes and female eyes. And actually, it reminds me of my training days. For some reason, 25 years ago, when I used to go to the ward, it smelled different. There was always sort of, I don't know whether it was the antiseptic smelled different. So these are the interventions which might be worth looking at. What's fascinating about all of this? You always come back, it's been discovered before. I don't know how many of you have been to a Qatari home or even a venue like this. You will come across the bahur. Now, this is a scent, and it has many, many advantages. You speak to many of the families here. Besides its spiritual enhancement and energy enhancement, there's also strong belief that it brings cleanliness. And this is one of the cleanest countries I've ever come to. People clean 5 times a day. It's not an issue here, but it's interesting to go back to history and see how bahur and smells and scents did actually change people's behaviors in terms of cleanliness. Moving to the next study, which is a concept that bothers most of us who do clinics, is what we call the no-show rate. Patient doesn't turn up to your appointment or their appointment in the hospital. That is, the prevalence of that is 1 in 10. It costs my own hospital, St Mary's, £5.5 million a year, because you have to remember, I'm sitting in my clinic, there's a slot, there is a nurse, 5.5 million. If you multiply that by all hospitals in England, it's about 600 million. And there are all sorts of reasons why patients think. In actual fact, some of them, when you ask them, they say, well, the hospital is so busy, so if I don't turn up, I might be doing them a favor because I'm not filling that slot. So we wanted to see how could we intervene in reducing the no-show rate or the DNA rate. This is a recent study, which was also done with the Cabinet Office, involved 20,000 text messages to patients. They get it on their mobile phone, telling them that their appointment at the cardiology clinic is at 16th of September at 10 a.m. What we wanted to do, this wasn't really working to the extent we wanted it, so we wanted to try which of these different messages will have the greatest impact. The first one was, if you want to cancel or rearrange, call the number on your, what a stupid thing to tell a patient, to go back to their letter to find the number to call the outpatients. No surprise, it doesn't work. The second one, to cancel or rearrange, this is the number, which is the third one is the norm. We are expecting you at the hospital, and we say in the text message, 9 out of 10 people do turn up to their appointment. You can feel the peer pressure on you when you know you don't want to be that one. You need to be one of the 9. Finally, which is more of the cost we put in there, we're expecting at the hospital, if you don't attend, the NHS loses £160 for that appointment. That's the guilt feeling associated with it. I wonder how many of you would think which is the winner, which is the one that had the biggest impact. Fascinating, I thought it might be the third, which is the peer pressure. Actual fact, it was the cost. You put the cost down, especially in a system like ours, even in the health system in Doha, everyone gets their treatment for free, outpatient for free at the point of need. When something is free, you don't value it. But if you know the cost for it, then you will start valuing it. Again, an interesting study in changing people's behavior without them knowing that you're doing it. Moving on into the concept of digital health, which is another wonderful innovation that's changing behaviors, but also enhancing our ability to deliver a safer healthcare. One of my colleagues in the patient safety group, who's Paul Ayling, published this paper recently, which really had the headline news in the United Kingdom, and that is, after looking at the data, we discovered something fascinating, which actually is not unique for England. It seems to be global, but people haven't really talked about it. And that is, my chances, the odds of me dying in a hospital if I'm treated on a Saturday or Sunday is double that if I went to hospital on Monday. Now that's an interesting fact in terms of what happens over the weekend. And that's created a significant political challenge in the UK. Some have attributed to staffing levels over the weekend. Some have said patients who come into hospital in the weekend are sicker than those who come in on a Monday. In other words, they're mostly emergency admissions. We wanted to look at one specific area of safety in a hospital setting, which is the issue of handover. Some of you will know from the days of doing 24 hours or a day and then going off one night off and coming back, All the regulations have changed in terms of the working time directive. We now work in shift work, certainly the fellows and the residents do. So we wanted to see if there are major gaps in handing over a patient from one doctor to another or from one team to another, and how would digital help us. 80% of the adverse events are due to communication errors, no different in any other industry. If you're unable to communicate and hand over a sick patient from one team to the other, ask any family who's had a member of their family in a hospital, the first thing they'll tell you is the communication side. They are usually the in-between. They listen from one doctor. When the new doctor, they tell the new doctor what happened previously because of the lack of communication. How embarrassing as a professional in front of the patient. I'll give you one example. If you really run the pathway of care, this is a patient in the ward who needs a catheter because they've gone into retention. So this wonderful guy comes up, who is the fellow, a senior guy, sees the patient, he bleeps his resident to come and put the catheter. The resident is doing something else, doesn't pick the message. The fellow moves on, patient is still waiting because the fellow left, he thought he's done the job, and the resident thinks he's doing another job, and he has to wait until he goes back there. And the message or the communication will fall in between. So what we looked at, what we identified from that, multiple issues with handover, prioritization doesn't exist. So it's an important issue. There's no overall coordination, and there's no overall trail of that information. So with the help of many of our computer scientists, we come up with this very simple technology, which is what we call the HARC, which is hand-based. Most of our trainees now have one of these smartphones, and what HARC does, it records the task, it prioritizes it because it has an artificial intelligence within the system, it understands and it learns as time goes on in terms of what is next. And you can see, for a resident's perspective, the different tasks they need to do, very clearly color marked, what needs to be done urgent, which is red, what is yellow, which is the amber, and what is the green. Recently at Wish, we also launched a wonderful app in actually collecting incidents and errors that happen on a global basis. That was launched by Her Highness in one of our innovation showcases. It was worked in conjunction with Hamad Medical Corporation, and Dr. Hanan is here, and really capturing, trainees capturing errors as they happen. Because you probably have heard me say this before, in life you can only improve things if you can measure them. If you don't measure things, you will never improve. Moving to primary care, and some of the work in that field, and I see Dr. Mariam here who runs primary health care. Diagnostic error still remains as one of the major causes of litigation in the United Kingdom and the United States. And computerized diagnostic support is becoming a real added value in terms of the electronic patient record, which we are about to install in Qatar. The project is funded by the EU and essentially looked at 34 general practitioners with 12 clinical cases, complicated diagnosis, one with the diagnostic support, computerized diagnostic support, and the other one without. And you can clearly see, just look at the diagnostic accuracy between those who had no diagnostic support versus those who did, a significant improvement. So technology will also enhance the ability of really improving safety incidents at a primary care level, which were mostly misdiagnosis or the wrong diagnosis. So, if I could move on to another area quite close to my heart, which is the concept of not changing people's behavior, but how could you really provide education and training in technical skills? And I know organizations like Hamad here have a wonderful skills laboratory, and I'm looking forward to the amazing training facilities and the simulation lab in the wonderful new hospital that, if you drive in here, just across the way, it's called Sidra, which has a huge simulation lab in terms of training the doctors and the nurses of the future in this country. Why do we do simulation? Because that learning curve that I had to do on a real patient could be learned in a lab. That's why a simulation lab is there, is to get over that learning curve. Why is it important in other industry? You probably would remember January the 15th, 2009. You remember this famous picture, a US Airlines flight which just took off from Newark Airport. It was an Airbus A320 piloted by Captain Sully, as they used to call him. And this is what he said at the end of it. After 42 years, I've been making small and regular deposits in the bank with experience and simulation. On one occasion on January the 15th, he withdrew all of his deposits to have that safe landing in the Hudson River. Simulation works because it's repetitive, it's structured, it allows you to make mistakes and learn from them. Obviously, systematic feedback and safety. And simulation has moved on to what it was 10 years ago. We now could do patient-specific simulations. And this is a concept in radiology, crossing cardiology, where you can take the patient MRI, reconstruct the images, put them on a simulator, not to learn the skill, but even the expert could rehearse on that specific patient before they actually do the procedure. So this is not generic simulation. This is actually the doctors practicing on my own anatomy in the lab before he does the real procedure on me. And this is what it looks like in the virtual environment, working on that image, and then moving on to the real environment the day after. Until you reach a specific competency, then you're allowed to go and do that procedure. And as you know, anatomically, variation in disease makes different patients different, so this is patient-specific. And if you look at the comparison between the two, tool changes, no tool changes, a significant improvement if a doctor has done that specific procedure on that patient in a virtual world the day before they did it in real life. Finishing off with one last section. One thing I've learned in life, you could never design a healthcare system, you can never design a good clinic, you can never design a good training program without talking to your customer. People hate me saying patient is a customer. Patient is a customer. You talk to that patient, they will tell you what is right and what is wrong. So patient engagement should be a core part of quality and safety. Why? Because patients are able to identify safety incident. You have to remember, patients know what's happening to them. My interaction with a patient might be for half an hour. I've no idea what happened when I left the ward. They are the only observer of the whole process of care, not just patients, their families too. Working with doctors will improve our knowledge, nurses and doctors' knowledge. This was highlighted clearly when Don Berwick did a report recently about the NHS. So one final study that we're looking into that has created a bit of controversy. I keep pushing the boundaries in St. Mary's, but one of these days they're going to get upset with me, and that is the concept of the mystery patient. You've heard of the mystery shopper. You train people to go and do shopping, and they will tell people who are selling stuff what is wrong with their shop. Very regular in big shops. If you go to Harrods, Selfridges, they have mystery shoppers. They walk in, they try and buy something and measure all their interaction. So we're training patients to have mystery patients. These are patients having surgery. We take them before they come in. We don't tell the clinical teams that are going to look after them that we've trained them for a whole day what to look for in terms of patient safety. Very clear set of criteria. So they become expert patients, and then they go to their surgery, and then they record everything in a computerized system or in a written note. So we now have our own patients coming into the system, giving a feedback on, I would have been very nervous 10 years ago if a patient who's been taught how to measure my performance in terms of quality and safety. We've done something not dissimilar with Dr. Hanan and the Supreme Council for Health under His Excellency's leadership, Abdullah, in looking at continual measurement of satisfaction of patients in the cancer hospital. We had a problem here. Patient satisfaction in cancer wasn't good enough, and there was a perception issue and a confidence issue. We improved the service, but at the same time as improving the service, we want to measure if that quality is improving. Very simple. They are measuring it dynamically, and there is a dashboard there which shows you in terms of safety and quality within the cancer services in Doha. Coming back to the end, and that is WISH. Something else I think is worthwhile mentioning to you is at WISH we launched the Leading Health Systems Network, the NHSN, and Mr. Egbert Schering probably is here, who is our CEO locally. And that is really bringing a community of health leaders and organizations together. And you can see the membership here, a large number of organizations coming together, coordinated through us in WISH, in Doha, in Qatar, and really driving some very interesting collaborations at a global level. We're about improving safety at a global level with partnership with organizations like ISQua and others. We're looking at patient information scorecard. What do different countries measure? Why do they measure? How could we learn from each other? We're looking this year at patient safety in maternity, which is ripe really once Sidra opens in terms of its maternity services. And then we have safety care and webinars that are there to underpin that. I'm going to finish off with a famous quotation, someone I've always admired, who's been my guiding principle when it came to quality and safety. In his day, in his time, we're truly committed to quality. Almost any mechanism will work if we're committed to that. I think I met Sheila Leatherman yesterday, who will be my second champion when it comes to quality. And these are the principles that should be guiding us in any change we make in clinical practice, at any change we make at a higher level, at a system level. So thank you again for the privilege of being here, and have a wonderful couple of days in Doha, a brilliant place to visit, and make sure you go to the souk. Thank you.
First one, on the hand washing data that you presented, you showed a big improvement with smell, but the level of hand washing was still in the 40%. What do we need to do to get to really to much higher levels?
I think it's a multiple approach. I think, as I said earlier, awareness is extremely important, but the question is, how do you keep that awareness exercise going? Leadership, ultimately, you walk to a ward, you know this ward is managed well because there is one nurse there who is a leader, who will tackle me, take me to the side as a senior consultant and say, you did not do this. Leadership, I think, is the main driver. And then you can add all sorts of the other interventions that I mentioned, whether it's smell or a vision or whatever else that comes with it. I wanted to use a camera system there because of human rights and patient rights and confidentiality. I was banned from putting a camera at the entrance of the ward, but that was fine. Interesting enough, what impact that would have had, I don't know.
And perhaps I'll ask you one other. Sidra is expected to open soon, which is very exciting. What advice would you have for them? It's obviously an extraordinary opportunity to be able to open a new facility.
Thank you for that. I wake up, it takes me a while to go to sleep every night because I have to give the advice to myself now. And what we're doing is, there's no question about the vision in terms of what it could do. We have an amazing organization. We have the right strategy. I think we have the opportunity in Sidra, being new, that is starting from bottom up, is to start it with the right culture. Because one of the challenges you have in any organizations is changing its culture. So when it comes to the human capital, ultimately, is the talent pool that you have that makes the difference. In terms of technology, in terms of the state-of-the-art facilities, how do we provide them how do we provide the executive team with the necessary tools in ensuring that that vision is met? Hospitals are complex environments. It takes a while to get them off the ground, but we are certainly back on track somehow in achieving the needs of the population here, which is tremendous and well deserved.
Thank you. So, other questions?
There's a lady there. No, we don't have a long-term, whether there is whether the impact reduces as time goes on. The experiment was there for about a week in each cases, but in most interventions, whatever it happens to be, you always get that dilutional effect, and you have to reinforce that somehow or the other. I mean, what you try to do with all of these techniques, may I just say, is changing behavior. That's the most difficult thing. Once you change your behavior, it becomes automated. So what you need to do is to make good choices easy to undertake. It's no different than dieting. Once you lose the weight, you've had that behavioral change not to approach your fridge every morning and taking a big bowl of a high caloric intake. Once you stop that, you actually, after a while, stop going back and doing that same habit that you've had before. Smoking is no different.
Hello there. Lord Darzi, David Galler from Kuawatea in New Zealand. It's taking that argument a little bit further about how willing governments are to embrace policy changes, whether it's through nudge or more specific regulatory devices, to improve our ability to prevent some of the non-communicable diseases that are overwhelming us. How willing are governments to do that, do you think?
I have a big problem not knowing whether did you know where it's coming from?
It is hard to hear, and I know the speaker, but I can't see where David is.
I'm here.
Yeah.
On your right in front of you, sir.
All right. Okay. How would nudge? I think if I get the story right, whether nudging and behavioral change has an impact in management of disease, absolutely, especially in long-term conditions, which are mostly lifestyle. Anything that is lifestyle disease. I'm talking about, type 2 diabetes, obesity, smoking. You can always use nudging techniques in changing that behavior, definitely. And there's plenty of work in that very important field. Yeah.
Can I?
So thank you, Lord Darzi, for a terrific session. Your Highness, Your Excellency, thank you again for hosting us here. I'd like to close this session.